I want to thank everyone for joining us today for our educational webinar on coronavirus and COVID-19 fact versus fiction. What is COVID-19? I am really excited to have one of the foremost experts in the world with us today, Marc Lipsitch, who is professor of epidemiology and director of the Center for Communicable Disease Dynamics at the Harvard T.H. School of Public Health. He's the author of more than 250 peer-reviewed publications and one of the world's top experts on the modeling of infectious disease transmission. So, Marc, I want to thank you for joining, and I know you're going to have you're going to present some slides to us about what is COVID-19, and then we're going to jump into some Q&A. So I'll turn it over to you to start.
Great, thank you. If I could have a second slide, I guess. Next slide, please. So many of you will have been focused quite a bit on this and will know much of this first slide, but this infection started in Wuhan, China a few months ago. It's caused by a virus that is related to the SARS virus, but quite different in terms of its epidemiology and its spread, which began in Wuhan and then spread to the rest of China and to the world. As of a couple of days ago, there were about 100,000+ cases in the world, of whom about 4% had died, and those are reports. Cases and probably even deaths are extremely underreported due to limited testing, especially in the United States, which as of the same time had about 1,000 cases reported. Responsible people are thinking that there are something like 50 times that in the United States, but could be a lot more, it could be a lot less, it could be a little bit less, but the testing is essentially no good, not nearly what we need in the United States, and so we don't have data on the actual number of cases. And when you hear about new cases, you're essentially reading about the discovery of existing cases as much as you are of actual spread of the virus. Severity is unclear because severe cases are the ones that we know about, making it hard to estimate really what the risk of dying is per case. But it seems to be around 1 to 2% for symptomatic cases, with much higher severity in the elderly, those with pre-existing medical conditions. Next slide, please. I think we'll skip this for now because let's go to the next slide. So for reasons that I'll explain in a minute, there has been a lot of emphasis on the notion of flattening the curve. Even has its own hashtag now. This is the notion that with no mitigation, an epidemic will spread rapidly, reach a high peak, and then as the number of susceptible people is reduced by the progress of the infection, it will eventually turn over and come back down. A flatter curve shown in the gray there is more desirable in the sense that fewer people are infected and the peak is lower. Next slide, please. We know from the experience of the 1918 flu that the cities in the United States that implemented control measures, collectively known as social distancing, early, such as St. Louis, experienced much reduced peaks of their epidemics and much reduced overall sizes of their epidemics. And these are two illustrative cases, but the statistics show that this was a generally true phenomenon in the United States in 1918. Early interventions led to flatter curves and flatter curves. Next slide, please. So why do we want to do that? There are three fundamental reasons. One is that in a flatter curve, overall fewer people get infected because there's less sort of lingering infection as the infection starts to go away from the population. Those who do get infected get it later, which is good because we're going to be learning over the coming months how to treat this infection. Maybe even antiviral drugs will be found that are effective against against it. Excuse me. And then most pressingly, the peak demand on healthcare is less in a flattened epidemic, and so we don't overwhelm hospitals, emergency rooms, and intensive care units. Next slide, please. We've recently done an analysis of this kind of overwhelming of the healthcare system in two cities in China, Wuhan, where it started, and Guangzhou, where it came later. They both closed down on the same day, January 23rd. But on that day, the Wuhan epidemic had already gotten quite far. There were already 500 known cases compared to 7 in Guangzhou. And I've shared the link to these slides, and you can look at them more carefully when they're distributed. But the take-home message is that Wuhan had a peak demand for intensive care that was equivalent to the entire capacity of the United States per capita. So they have 11 million people. We have a lot more than that, but per capita, their demand for intensive care was comparable to what we have in the United States, and about 3 times the available bed space. And that was due to late interventions and a continuing buildup of need for intensive care as people got sicker and sicker who had been infected before the interventions. Next slide, please. So there's a big move right now to so-called flatten the curve, reducing social contacts in various ways that are listed on this slide, canceling public gatherings, closing houses of worship, restaurants, theaters, etc. One thing that's often overlooked, and that as corporate people you can have an impact on, is improving the ventilation and humidification of buildings. This is a link at the bottom to a New York Times article by a colleague of mine about the role of building ventilation in virus transmission. Another aspect that you have direct control over is allowing paid sick leave for all workers for COVID-like symptoms. And fixing the incentives for people to come to work ill, which are in place especially for hourly workers, and even in healthcare settings still, those incentives are backwards. I should say that in the absence of, despite what the president has said, we are nowhere near, we are at least a month away from the possibility that people with mild illness could en masse be able to get tests. That is not a sustainable strategy at this point and won't be for a long time. So it's really going to have to be symptomatic decision about whether to stay home from work, not a COVID test. It's just not going to happen on a large scale. And moreover, as we move out of flu and cold season, COVID is going to be the major reason why people are sick with those kinds of symptoms, I believe. So those are some of the corporate aspects. We could talk about others. Working from home is another one. And at the societal level, we're thinking obviously about considering school closing. Next slide, please. There's a movement in many places around the country now to go from a very case-based approach to containment, as it's called, meaning focusing on trying to find each case, isolate them, find their contacts, and have them stay home, which doesn't really work if we're only catching a small fraction of cases, as is the case in the US. And so the movement is more towards those measures I described before of social distancing and trying to make workplaces and other places where people are less high transmission areas. Next slide, please. The sense of urgency, I think, comes from the experiences in Wuhan with late interventions leading to problems with the healthcare system. And now we're seeing in Seattle maybe the beginnings of a similar thing, and in northern Italy, certainly very intense stress on the healthcare system, people being unable to get treatment for life-threatening illnesses because there just aren't enough healthcare personnel. And this graphic from the Financial Times a few days ago suggests that we are, in the US in pink, we are perhaps a week and a half away from the same situation as Italy. So this is why there's a sense of urgency to try to really reduce transmission as much as possible to at least try not to get to the point of crisis that Northern Italy has been in. That's my presentation. I'm sure there are lots of questions, and I'm happy to expand on any of it, but I think your questions will be more targeted at what you're interested in. So let's move to that.
Okay, great. We'll jump into the questions. Thanks, Mark. And so right now we're on a trajectory towards what happened in Wuhan in Italy and potentially like a week and a half away. Is that what you're saying?
I think that's the best guess that we have. I mean, the problem is it's hard to visualize without testing, but there is a significant concern among all epidemiologists that I know that's where we're heading.
And we're past the point of containment, right? Because of the fact that there's the testing, lack of testing, and we need to move to how do we mitigate it, like you were saying in the Philadelphia example.
Exactly. I think there are some specific situations. If you have a nursing home and you know there's an exposure, trying to deal with that one by one is of course appropriate for the high risk people in that nursing home. But as an overall policy, we're not going to stop the epidemic by one at a time kinds of interventions. It's got to be at a social level.
And you had said, it could be the cases that, because the testing is very limited and in some cases not working, it could be 50 times as high. So how many actual cases do you just estimate that, for example, the US has, and what could be the highest potential number? And is this also in every major city in the country already?
I don't think we know because the data are just so poor quality and so different from place to place. So what I'm saying is kind of a judgment rather than even a scientific judgment. It's a kind of gut feeling, but based on the science as much as possible. I think 50-fold is a pretty good guess at how many there are. I don't think that we're at 1 million cases yet, and I don't think that we are as little as 10,000. I think we at least are missing 9 out of 10 and maybe 49 out of 50. But they're all, those are very different. And I think geographically, it just showed up in South Dakota a few days ago. It's not limited to New York and LA, let's put it that way, whether it's everywhere. I do think actually, based on the way that the epidemic spread, it's quite likely that the burden is different in different places, simply because at random, sometimes epidemics take off earlier and sometimes they take a little while. And there's some biology and math underlying that, but just suffice to say, it may be 10 times bigger per capita in one place than another, but that's still, but I think it's in many, many places.
If when you say like it could be as high as 50 times, let's say if it was 50,000 cases, how fast does this COVID-19, can it go from like 50,000 to 1 million? Is that, because I think people would want to know, is that a couple days? Is that a month? Is it a week? How fast is it spreading?
Right. It's really hard to disentangle the spread from the discovery of old cases, as I mentioned. So on that graph from the Financial Times, it says it's doubling every 3 days, which means that 100-fold takes about 6 times 3 is 7 times 3 is 21. So about 3 weeks to get 100-fold. Most other estimates are that in Wuhan before the crackdown, it was doubling about every 6 days. So that would make it twice as long. And I think probably it's somewhere in between, maybe closer to 6 days. But still for a doubling, but still that means 6 weeks from now, we'll have 100 times more cases, which is, if it's 50,000 now, is 5 million cases.
Now, the CDC has created different scenarios that they worked with 50 experts on, with projections like potentially up to 160 million to 214 million infected, fatalities 200,000 to 1.7 million. Where do you think we're going to end up here in the US? And will that be similar to what's happening globally?
I think it depends on a lot of things, how well we mitigate, how long we can keep those measures in place. I'm not ready to predict which of those scenarios is right. I think my own view is that in the end, there will be 20 to 60% of the adult population infected, which is not far from those numbers, and that of those adults, around 1 in 200 of them will die, so 0.5%. But those are both very rough numbers, and it could be different.
So when people keep comparing this to the flu, I've been talking to a lot of insurance executives, a lot of large employers, even associations. We pushed out some statistics and infographics yesterday, really share with them the difference. Can this even come close or compared to the flu with the fatality and the infection spread?
This is worse than any seasonal flu we've ever had. If the 0.5% per infection is right, it's worse than any seasonal flu we've ever had, by far. It's worse than the pandemics other than 1918. So 2009 flu pandemic, the 1968 and 1957. Whether it's worse than the 1918 flu is unclear, but it's in that league, I would say.
Is there a possibility?
The comparison to the flu is, unless people are thinking of the flu in 1918, is totally inappropriate.
So, China went to war against COVID-19 and locked down the entire country. Is this going to be like, the US like mobilizing for war, to fight it? And is that even realistic here versus, in governments like China or the Middle East where, they can lock everything down and everyone listens and follows the distancing and all these different, philosophies?
It's the American experiment. We will find out. I don't know. I think very intense measures right now to slow things down are totally appropriate. Whether they will happen in time to avoid the sort of Northern Italy-like phenomenon, I'm not sure. I think individual people will see the desirability of locking things down as they start to see pictures of hospitals they know overwhelmed. But it's going to be a long slog, because the problem is, if you slow it down successfully, as you saw with that flatter curve, it's a lot longer period. You have to keep those interventions in place. And I think some people haven't processed that with China, they've gone to war, they've brought it down to almost nothing. They're now, if I have heard correctly, they're now having a travel ban from the US because we're a hotspot of transmission and they're not. And that the problem is going to be that if you let up, as China is beginning to do, the virus is going to start to spread again. It's not totally gone from China, in my opinion. And if it is totally gone, they're going to have enough influx of people from other places that it will be back. So the problem, the dilemma, I mean, and I don't have any good answer to this, is you can either have a really intense, bad overwhelming of the healthcare system and get it over with, which seems to be roughly what the UK is trying to do, and what other countries that can't afford or manage really intense interventions are going to do by default. Or you can have these interventions in place for a long time, but that's very costly.
We hear the word peak, like, when is this going to peak? I've heard from some, infectious disease experts, throwing around dates very quietly, like, it could be June 7th, but nobody really knows. And what is a peak? And when do you think a peak may or may not happen? And what happens after the peak?
It's very hard to say. I mean, there are sort of temporary peaks, and then there's the peak because so a temporary peak, I don't have a date for you. The temporary peak might happen if we control transmissions to a sufficient extent through social distancing measures and others, that each case makes less than one additional case. And that's what makes epidemics peak. And that's what happened in China. Then if you let that off, then you have a rebound and you keep getting more cases. And if you look back at the slide from St. Louis, you can see that as in the middle of around the end of November in St. Louis in 1918, they let off on some of their interventions and they got another peak. So it's just not meaningful at this point to say, because it's completely a function of how well we intervene and how long we keep the interventions on.
For people who have chronic conditions, that have a higher rate of fatality. For them looking at, if I'm going to stay home to avoid this and wait for treatments to come out, or the surge and the crush to the healthcare system, how long should they prepare? Is that 1 month, 3 months, 5 months, kind of mentally thinking or even preparing from a food or medication standpoint?
Yeah, I think it is going to be months, several months. I don't know how many months. Um, and uh, and it may not mean never going out of the house. I mean, I want to emphasize a lot. We've been pushing, my colleagues and I, for large public gatherings to be canceled, including some of the outdoor ones like parades and things. But being outside is not, there's nothing bad about being outside the house or about being inside the house. The problem is density of people and poor ventilation. So it's not that you can't leave the house for 6 months, but it is that you should probably have someone else. If you have a high risk, you should probably have someone else go and pick up your medications and your food for you if you can.
So my dad's 80 years old. I'm scared of him leaving the house. Is that a scenario with that 14.8% death rate? Stay home and let family members get him what he needs?
I'm not sure what 14.8%, where was that?
I've seen a stat that was published that was regarding, over 80 years old.
Over 80. Yeah, maybe that high. I can't remember anymore. Yeah, again, that's if you get infected, not if you don't, obviously. But yes, I mean, it would be good to have, again, not to stay in the house the whole time, but to avoid places where there are lots of people who could be infectious.
Mhm. Now, I know there's talk about vaccines, people saying it's 1 to 2 years, some people saying it's a couple months, potential development of potential treatments, whether that could fight HIV. I heard recently China's using a Japanese, treatment, which you're saying can take 4 days and cure it. What's the reality? But there's only 2 million doses supposedly, but what's the reality with all the information out there on, vaccine or treatment plans?
So vaccines and treatments are different stories. Vaccines are going to take at least a year, and that's a very, very aggressive best case scenario. Could be longer, considerably longer. Treatments are easier to test because they already exist. I mean, they're antiviral drugs that were designed for another purpose, and they are being tested. And so I think in a few months we might have a knowledge that particular antiviral drugs work, and then the manufacturing capacity is the next hurdle, because most of these are HIV drugs or malaria drugs or other things. So stay tuned, but I think that's the nearer term hope, is for treatments.
And there have been estimates that between 2.4 million to 21 million people could be hospitalized. Two questions: is that accurate? And if we only have about under 1 million hospital beds, any reason why some of these projections really haven't been shared with hospitals or others so that there can be proper preparation? And what do you think is going to happen in the hospitals? Is it, have you heard what's happening on the ground in Seattle? And if that's mirroring what's going on in Wuhan?
So Wuhan is now much better. Seattle is ramping up to Wuhan-like levels. Hopefully they won't reach them, but less than a day ago, I read an email from a pathologist in Seattle whose lab is completely overwhelmed, and they have a lot of surge capacity because they're in a real biomedical center. And yes, hospitals, I hope hospitals are aware. It seems like there's a little bit of a disconnect from these numbers, and I'm not sure about the exact figures you gave, but Wuhan and northern Italy and Iran and other places with actually pretty good healthcare systems. I mean, people in Boston are pretty snobbish about their healthcare systems, and one of the doctors from Mass General yesterday described northern Italy as having comparable quality healthcare to what we have. So they are completely overwhelmed. If hospitals are not getting the message, they're being hit in the sand.
Employers, a lot of most of the employees around the country are covered by employers through self-funded healthcare. What should they expect in the ability for their employees to have non-COVID-19 access to healthcare, emergent care, emergency surgeries, like chemo treatments, things like that? And what are the risks of those people actually going into the hospital, for that medical care while, COVID-19 is being dealt with there?
Yeah, it's going to vary a lot locally by how the hospitals set things up, whether they concentrate the COVID cases in one place or whether every hospital tries to deal with it. I think it's really hard to say. It could be very disrupted. I think in northern Italy, it's certainly being disrupted. There's nothing but COVID right now.
The Abu Dhabi government just yesterday announced that any employees working for the government that are vulnerable, that have chronic diseases, are going to work from home. And my question is, if it was your decision, on whether it was closing workplaces, letting chronic, employees work from home, closing schools, what types of things would you say, we need to, close to really, contain the spread of this?
I would close everything, for sure. I would close everything except schools and mass transit. I am leaning towards saying close schools and mass transit as well, but those are so disruptive that, as I told the mayors that I was talking to on the last call, I'm glad it's not my decision, because it's an agonizing choice, and I don't have an opinion. I have an opinion about disease control, but not about the total social cost. In terms of working from home, absolutely. If people have chronic conditions, that's a good idea, assuming that their homes are not themselves a place where they're likely to get exposure, like from a school kid or from a kid. So I think the thing to remember is that workplaces are dangerous insofar as people are touching each other, people are not washing their hands, people are densely packed per square meter in the office space, and homes are kind of the same thing. So there's nothing magical about a workplace or about a home. It's about how much social contact you have with people who could be infectious. So I talked to a law firm, a fancy law firm yesterday, which is going to think about an A-B model where they have half the people come in each day, and in shared offices, it's one person one day and one the other. So that's a model where it's maybe less disruptive. It is reducing the density of people and the density of interactions. And if you're in New York City, maybe your house is actually a more densely packed place than your law firm office. So people should try to think about the mechanics of how transmission happens rather than like workplaces are bad or houses are bad or good or those things. It's just about people touching people and breathing on people.
With that, there's that social distancing and then the social responsibility, which plays a huge part. People not wanting to give up interacting, going to events, younger people who see the stats and say, this doesn't affect me. I'm not going to have any symptoms, or I have no chance of really dying. And so I'm just going to go out and live life. And we're trying to educate people. Okay, well then you go interact, you get someone sick and they get someone sick and someone's, potential father, grandfather, or someone like a young woman with a suppressed immune system, gets it and has a fatality. What's the importance of the social distancing and us taking social responsibility to not get other people sick?
Yeah, I think you've stated it very well, that the social distancing is a societal phenomenon, and it's all of us doing it that makes it work. It's a lot like vaccination. It's you do it for yourself and you also do it for other people. And it's true. It's really unpleasant. My own kids are not thrilled about missing school and missing their friends. But we're also, they're going to see their friends sometimes one-on-one at a distance. They're not going to completely end social contact. So I think part of the way to square that circle is to try to find ways of maintaining human contact, which is not high risk. So out of doors is better than indoors, small groups better than large groups, those kinds of things. And as the weather gets better, that will be easier to manage as well.
Is this going away in the warmer temperatures as people are trying or reporting?
It may go away. It will not go away. It may slow the spread some, and we certainly hope it slows the spread some. But we don't. There's very little reason to expect it will totally go away in those warmer temperatures.
Now, when you say your kids are going to meet their friends, but at a distance, there's a lot of parents I'll talk to who will say, I'm going to let my kids play. I'm not going to worry about it. What are you doing, and what is the reason, so people understand?
Yeah, well, our kids are older, so they're they're able to contain their snot, to put it bluntly, and so for younger kids it's a little bit harder. But for older kids, the idea is they're gonna see people. They're not gonna touch each other. They're not gonna share food, although it's not clear that sharing food is a major problem, but as a precaution. They're gonna wash their hands frequently. We'll do it as much out of doors as possible. And so it's just, there is a human need for interaction, and you can't suppress that for months at a time and expect things to go well. So it's a balancing act, but I think we know some ways to make it less risky for transmission, and that's what we'll do.
Are you doing that so that they don't infect others, or is it because you don't want them to be infected or you to be infected?
Both. It's all because with kids the infection is so mild. You really don't know whether you're a potential source or the friend is a potential source, or both, or what. So we're just it's for all those purposes.
Mm-hmm. I mean, people might say you're young, your kids are young, there's no worries. Why really be concerned? Because I think that's what a lot of people are thinking.
Well, I have parents who are not in town, but I have in-laws who are sometimes in town. I have contact with school teachers and other people and colleagues. So in my case, I may be a little bit higher risk than some myself for certain reasons, but also, I think it's a social responsibility to try to slow down the transmission as a member of the society.
Should employers expect supply chain being broken? And what should we expect, whether it's food, parts, supplies, medicines, customer, being open or businesses being closed, based upon what we've seen in like Italy and in China?
Yeah, I don't know yet how that's going to work. Clearly, some pharmaceuticals, and in fact, some of the ingredients for lab testing kits for this virus are made in China. And so those are concerns as their economy is on pause right now. I think their economy is going to get off pause, and then they're going to have to go back on because the virus will come back. So I think prepare for many disruptions, and hopefully some of them don't happen.
Mm-hmm. What would be the best way for employers to prepare, if we were to give them some final insight before we kind of wrap everything up?
I think get your buildings in as good shape as you can. Get your plans for people to work from home insofar as they can, if that's a real option in your industry, or to reduce staffing levels in some places, if that's also an option, by having partial work at home. Prepare for disruptions to mass transit if that's going to be closed in some places, which I think it will. I think it's going to be a full-scale economic slowdown and societal slowdown. So trying to have some resilience to that.
Should employers expect quarantines like what's happening in Italy?
Um, I don't know. I have to say, I was worried a few weeks ago when people would say, "Should I go to, France for a vacation?" I said, I think there's no rational reason why anyone would shut off travel from France, uh, because we have probably as many cases as France. But I don't trust that the government at this point is acting rationally, and I wondered if I was just showing my political views, uh, but sure enough, we rather irrationally made a whole big travel ban from most of Europe except for the UK a couple days ago, and there's talk of doing it domestically. So I don't have a lot of faith that decisions are going to be made in an evidence-based way.
Well, thank you, Mark. Really appreciate your time and insight. I know you're super
Yep.
busy, and thank you so much for giving us your time.
Thank you for having me.
Take
Bye-bye.
care.